Great. Well, hi, everybody. Welcome. I'm Zach Liederman, physician here in Toronto that's moderating today. For those that are new to our National Thrombosis seminars, these occur monthly. They are accredited by the Royal College for CME credits. Now, if you mind going to the next slide. Curriculum, or the program, was developed by our planning committee, chaired by Dr. Sufei Wang. So we have two excellent speakers today on use of oral anticoagulation in patients with end-stage renal disease. So Dr. Thomas Mavrikanis is a nephrologist at McGill University, a clinician scientist at the MUHC Research Institute, and assistant professor at McGill University. He has a research focus on causes and treatment of cardiovascular disease in patients with chronic kidney disease and kidney failure. And he's joined by Dr. Alexander Benz, who is a cardiologist and completed an EP fellowship at the University Medical Center, Johannes Gutenberg University in Mainz, Germany. He's an international fellow at the Population Health Research Institute at McMaster University in Hamilton, and has a primary research interest in antithrombotic therapy and stroke prevention in patients with atrial fibrillation. So I'll let the speakers get into this in more detail, but a quick overview of our learning objectives for today. Okay, if you can go to the next slide whenever you're ready. And as a reminder, we're going to reserve some time at the end for any questions. So please submit any questions you have on the platform during the presentations. So with that, I'll turn it over to our speakers.
So thank you very much, Dr. Liederman, for the kind introduction. Dear colleagues, thank you for joining us for this seminar today. So these are my disclosures. We already went through the objectives of this presentation. So as you all know, atrial fibrillation is a common arrhythmia in patients on dialysis. This study is a meta-analysis of patients on maintenance hemodialysis who have an implantable loop recorder. And it shows that new or recurrent atrial fibrillation is actually seen in 26% of patients on maintenance hemodialysis. So this arrhythmia is not only very common, but is also associated with poor clinical outcomes. Once you are diagnosed with atrial fibrillation, the probability of survival declines as kidney function declines and is worse in patients with advanced renal disease. Similarly, the patients with atrial fibrillation who get an ischemic stroke do worse when they have advanced kidney disease compared with patients who have a stroke but also have preserved renal function. Something else that is probably a bit less known is the pathophysiological mechanisms of stroke as kidney function declines. In this work done by one of my fellows when I was in Switzerland, we showed that the incidence of ischemic stroke decreases as kidney function declines. 76% of strokes are ischemic in origin in patients with chronic kidney disease of any stage, but when these patients progress to dialysis, the relative incidence of stroke, of ischemic stroke, is only 59%, the rest being hemorrhagic strokes. Traditionally, we would treat a patient with atrial fibrillation who is dialysis dependent with warfarin to prevent a new stroke. I will show you in the next few slides why this practice is becoming less and less common in this population. First, we do not really know if warfarin protects against stroke in hemodialysis. There is no randomized study ever examining this clinical outcome. However, we have several well-conducted observational studies done in different settings and in different populations across the world. And most of them saw that there is no difference with respect to new strokes when you use warfarin in patients with atrial fibrillation who are on maintenance hemodialysis. On the contrary, you get more hemorrhagic strokes, a 46% increase in the relative incidence of hemorrhagic strokes with warfarin compared with no treatment. Furthermore, when you use warfarin, the bleeding risk goes up. This is the incidence of major bleeding that is increased by 20% in dialysis patients who are treated with warfarin, and there is no benefit with respect to mortality. Why warfarin does not seem to work in dialysis is not entirely clear. One of the factors that may explain the reason of the inefficacy of warfarin in this setting may be actually the fact that it's very difficult to achieve therapeutic range with vitamin K antagonists in general in end-stage renal disease. Dr. Bench will present these clinical trials in detail a bit later, but even in a randomized clinical trial setting, which is probably the best setting that we could imagine for these patients, you see very low percentage of patients being on therapeutic range when treated with vitamin K antagonists. Another important consideration is calciphylaxis. Calciphylaxis is a relatively rare condition that manifests itself with widespread vascular calcification and finally presence of ulcers and ischemia. And this condition is very common in patients with kidney failure who are treated by warfarin. So warfarin increases the relative risk of calciphylaxis by a factor of 3 to 13, probably because of the inhibition of certain metalloproteinases that are vitamin K dependent. Calciphylaxis has a 50% mortality rate in dialysis. 1 out of 2 patients with this condition will die several weeks to months after diagnosis. Finally, vitamin K antagonists may undermine clinical outcomes by inducing anticoagulant-related nephropathy. This condition is important in dialysis because even in these patients with very low renal function, it's still important to preserve residual urine output. This has been shown to be associated with better clinical outcomes. So we know that across the spectrum of CKD, when you treat patients with vitamin K antagonists, they may develop unexplained acute kidney injury associated with macrohematuria, and the histological findings are actually red cell casts in the tubules with unremarkable glomeruli. This condition is less commonly seen with the direct oral anticoagulants. So if I convinced you that warfarin may not work in dialysis and may be associated with adverse clinical events such as calciphylaxis or loss of residual renal function, let's see what we know about use of the direct oral anticoagulants in this setting. So all these agents are eliminated by the kidney in various degrees, and this becomes significant when creatinine clearance drops below 50. Rivaroxaban and apixaban are the less renally eliminated agents. Rivaroxaban is only 22% renally excreted. Apixaban, sorry, it's only 22%. Rivaroxaban is 33%. Apixaban, due to the very low renal elimination, draw much attention since the beginning, and there was a first study that evaluated exposure to the drug after a single dose. This study concluded that the exposure to apixaban is similar in patients with kidney failure or in patients with preserved renal function after a single dose of 5 milligrams. And this paper led to much confusion, and this conclusion is totally unfounded. Because as you know, all agents that are renally excreted will accumulate, and you need several half-lives to see actually the real exposure to the drug after reaching steady state. This is actually why I designed this study with apixaban in dialysis that was conducted a few years ago. So we gave apixaban for 8 days until we reached the steady state, and we did the pharmacokinetic curves on day 1 and day 8, and then we repeated the study with the full apixaban dose, so 2.5 milligrams in phase 1 and 5 milligrams in phase 2. We used an anti-10A assay to assess apixaban concentration, and we used well-established exposures at steady state from phase 2 studies as the reference range. And what we saw actually is that there is significant accumulation of the drug between day 1 after the single dose and steady state. This was seen with both doses. And what we found is that the percentage of patients with apixaban at the full dose may get supratherapeutic drug exposure. On the other hand, patients who receive the low dose are never supratherapeutic, but some of them may be at the lower spectrum of what you would expect in the general population with the full dose. We also showed that the medication is not removed by dialysis, which is not surprising because actually it's heavily protein bound. Our results were confirmed by pharmacokinetic data from the recently published Renal AF study, and Dr. Bench will guide you through this study in a few minutes. But what we can see here is that there is gradual increase in exposure, and you may not be able to estimate very well the difference, because what you see here is AUC 0 to 12. What we had in our studies AUC 0 to 24. So from a 24-hour exposure of 2,600 in patients with normal renal function, you would go to more than 5,000, and you have an important percentage of patients that clearly overshoot. You do not see the same effect with the low dose, as we also showed in our pharmacokinetic study. There is also one very well-conducted study with rivaroxaban in dialysis, and this study, using the same methodology as ours with repeated dosing and confirmation of steady state, showed that 10 milligrams of rivaroxaban is probably equivalent to 20 in the general population. Before going through the clinical trials that compared apixaban with vitamin K antagonists, one may think actually about the right question to ask in this setting. If warfarin is associated with poor clinical outcomes and does not protect against stroke, maybe giving warfarin to the control arm is not the best option. Perhaps direct oral anticoagulants should be compared with no treatment. Unfortunately, there is no randomized data on this question. There is just one observational study that we published a few years ago using the United States Renal Data System. This is a big retrospective cohort of all dialysis patients in the United States. And we were able to match 521 patients on apixaban with 1,500 patients who did not receive any anticoagulation. Matching was done on the basis of a propensity score, taking into account 25 variables at baseline. And we examined apixaban use as a time-varying covariate. after matching, the two cohorts were actually well balanced across all baseline characteristics. And unfortunately, we were unable to find any benefit from apixaban use with respect to stroke prevention. But we did find more bleeding, and this is fatal or intracranial bleeding with apixaban compared with no anticoagulation. And this increase in bleeding was mostly due to the full dose of 5 milligram BID, as also suggested by the pharmacokinetic data. Increase in bleeding was not significant with the low dose. And surprisingly, you also see an increase in any stroke with the full dose of apixaban, which is probably driven by hemorrhagic stroke. Remember now what I told you before about the pathophysiological mechanisms of stroke as kidney function declines. But unfortunately, even in the low apixaban arm, there does not seem to be any benefit from apixaban use in this population. Risk of bleeding becomes even higher when you use an antiplatelet agent at the same time as oral anticoagulation. This is data from the same study. The risk of bleeding is numerically higher without an antiplatelet, but when you add an antiplatelet to apixaban, it's clearly much more important. So we'll stop here, and if we have a few minutes at the end of this presentation, we may come back with the scarce evidence on venous thromboembolic disease. But for now, let's discuss the evidence from clinical trials with direct oral anticoagulations in dialysis. So, Dr. Benz, the floor is yours.
Thanks very much. Happy to be here. Thank you all for joining today's seminar. We'll now have a look at the completed randomized trials in the field, and we'll then review the ongoing and planned trials that will probably be even more informative. Before we conclude the session, we'll take a brief look at the 2020 CCS, Canadian Heart Rhythm Society guidelines. I have nothing to disclose in relation to this presentation. Let's start with the completed trials of oral anticoagulation therapy in patients with AF and end-stage renal disease who are on dialysis. For now, we have 3 trials that are completed and that have been all published very recently in the last 2 years. You can see very easily that all these trials randomized patients to a factor Xa inhibitor versus a vitamin K antagonist. The names of the trials will come up a couple of times more today. The first one that we will review is the Valkyrie trial. Now, Valkyrie randomized patients with AF and patients at the same time were on dialysis to a reduced dose of rivaroxaban 10 milligram once daily or a vitamin K antagonist. So technically 132 patients were randomized, 44 to receive a vitamin K antagonist with a target INR of 2 to 3, and 88 patients were randomized to receive rivaroxaban at the reduced dose of 10 milligram once daily with or without a vitamin K2 supplement. Now, the Valkyrie trial was originally designed to study the effect of vitamin K status on the progression of vascular calcification, so it was not technically a clinical outcome trial. However, we do have, and that is good, clinical outcome data through a duration of a median follow-up duration of about 2 years. Technically, this was a 3-arm trial. 132 patients were randomized to receive a vitamin K antagonist, Riva-10, or Riva-10 plus vitamin K, which is menaquinone, 2 grams administered thrice weekly after dialysis. Now, in some of the results that I'm going to show you, you'll see that the Riva arms were actually pooled because there were no differences observed in the main outcomes. These are some selected baseline characteristics of the patients that were enrolled in the Valkyrie trial. You can see that the median age was actually quite advanced at around 80 years or so. Majority of patients were male. About a third had a prior stroke, and then a typical pattern of cardiovascular comorbidities. What I found interesting and remarkable is that there was quite a high rate of concomitant aspirin use in these patients. About a third of patients received aspirin in addition to the randomized oral anticoagulant treatment. INR control in these patients seems to be very challenging. Dr. Mavrokanis mentioned this earlier to you, but you can see here the time in therapeutic range per 6-month interval for patients randomized to receive a vitamin K antagonist in the Valkyrie trial. And in the first 6 months, only 48% of patients were in the therapeutic range. The remainder of patients, so the majority actually was not in the therapeutic range, with being in the subtherapeutic range being more common compared to being outside of the therapeutic range but over. There was some improvement in INR control over the duration of the trial. However, even in the last 6 months that are on the slide here, we're far from perfect and probably much worse than what we can achieve in the usual patient with AF that is on a vitamin K antagonist. The primary efficacy endpoint in this clinical outcome data study from Valkyrie was a composite of fatal cardiovascular disease or non-fatal vascular events. The median follow-up duration was just short of 2 years. And you can see in the Kaplan-Meier curve that patients on rivaroxaban, that is irrespective of whether they received vitamin K2 or not, did better than patients who were randomized to receive a vitamin K antagonist. This advantage resulted in a 59% relative risk reduction in the hazard for the primary efficacy outcome for rivaroxaban 10 without vitamin K2, and a statistically significant 66% relative risk reduction in the hazard for the primary efficacy endpoint for patients who were randomized to receive Riva-10 plus vitamin K2. As I mentioned earlier, there was no difference between the rivaroxaban arms. These are some selected secondary endpoints from the Valkyrie trial. You can see that death was by far the most common outcome, 73% versus 65%. In comparison, ischemic stroke was fairly uncommon, happening to 16% of patients randomized to receive a vitamin K antagonist and 7% to patients randomized to rivaroxaban 10 with or without vitamin K. And that is during a median follow-up duration of just short of 2 years. 5% of patients in the vitamin K antagonist arm experienced a hemorrhagic stroke. There was no such patient in the rivaroxaban arms. And you can see that the rate of life-threatening or major bleeding was approximately doubled with the vitamin K antagonist compared with rivaroxaban. And you can see that the absolute rates were actually quite high at 39 versus 19%. Let's continue with the second trial. That's the Renal AF trial published in Circulation a while ago. This study randomized patients with AF and end-stage renal disease on dialysis, so the same population, to the full dose of apixaban, which is 5 milligrams twice daily. The patients who were older than 80 years or with a body weight of less than 60 kilograms, the patients were receiving 2.5 milligrams twice daily. The comparator in this renal AF trial was warfarin, again with a target INR of 2 to 3, and the primary endpoint here was the composite of ISTH major or clinically relevant but non-major bleeding. You can see on the slide that the investigators aimed to achieve a planned sample size of 762. And originally, this study was designed as a non-inferiority study aimed at demonstrating the non-inferiority of apixaban at the full dose compared to warfarin. However, the investigators did not achieve the enrollment target, and at the end, only 154 patients were randomized, 82 to the apixaban arm and 72 patients to the warfarin arm. These are the baseline characteristics, or a selection of them in the renal AF trial. You can see that on average, patients were a lot younger than those enrolled in the Valkyrie trial, about 10 or 11 years younger. The majority of patients enrolled were male. The majority of patients had paroxysmal AF, and about 20% or so had had a prior stroke prior to enrollment. Again, very high rate of concomitant aspirin use in these patients, around 40–45% in both groups. And that is in addition to the randomized treatment, which was apixaban or warfarin. During a median follow-up duration that is just short of a year, the primary endpoint ISTH major or clinically relevant non-major bleeding occurred to 26% of patients in the apixaban arm and 22% of patients in the warfarin arm. And this corresponded to a non-significant 20% relative increase in the hazard for the primary endpoint. Similar to what we've seen in the Valkyrie trial, time in therapeutic range was suboptimal at only 44%. And that is, again, as Dr. Mavrokanis mentioned earlier, in a probably best case scenario with regular study visits and physician oversight. So very challenging to get good INR control in patients on vitamin K antagonists who have AF and are on dialysis. There are secondary endpoints reported as well for the renal trial. You can see that death, again, was the most common outcome, 26% versus 18%. There was only one ischemic stroke in the apixaban cohort and 2 in the warfarin patients. Hemorrhagic stroke was rare, only 1% in the apixaban arm, none in the warfarin arm. And the rates of major and clinically relevant non-major bleeding were non-significantly different between the two groups. However, there was a numerical increase in these events, in bleeding events with apixaban compared to warfarin. The third trial that we're going to discuss is the Exadia AFNet-8 trial. I'll just try to keep it short and call it Exadia. This is a trial in the same population that randomized patients to receive the reduced dose of apixaban, which is 2.5 milligrams twice daily, or a vitamin K antagonist that is very popular here in Germany, and that is a German trial that is called fenprocoumone or Marcuma. I'm pretty sure that you guys are probably not so familiar with it. Fenprocoumone, compared to warfarin, has a longer half-life, other disadvantages. So I think it's very common over here and not very common outside of Germany. The primary endpoint of the Exadia trial was a composite outcome of all-cause death, major and clinically relevant non-major bleeding. The original planned sample size was 222. And also, this trial was planned as a non-inferiority study aimed at showing the non-inferiority of apixaban to the vitamin K antagonist that was tested in the trial. Again, we had significant challenges in patient enrollment. In the end, only 97 patients were enrolled. So again, the target enrollment was not met. 48 patients ended up in the apixaban arm, and 49 patients were randomized to receive a vitamin K antagonist, again with a target INR of 2 to 3. Baseline characteristics of the patients that were enrolled are shown on the slide. The median age is probably in the middle between the patients enrolled in the Valkyrie trial and the Renal AF trial. Median age here around 77 years. Again, the majority of patients were male. We don't have any data on the type of AF or the proportion of patients who had a prior stroke. But again, and there seems to be a recurring theme, quite a high rate of concomitant aspirin use in these patients, again, a third or so, although the investigators note that chronic use of aspirin was actually an exclusion criterion. During a median follow-up duration of almost 1.5 years, the primary endpoint, which was the composite of all-cause death, major or clinically relevant non-major bleeding, occurred to 46% of patients in the apixaban arm and 51% of patients randomized to receive the vitamin K antagonist. And this corresponded to a non-significant 7% decrease in the hazard for the primary endpoint, quite a high confidence interval So again, and similar to the previous trial, an inconclusive result, and you can even see that the margin for non-inferiority was not met, probably due to limited statistical power. Another recurring theme seems to be the challenging INR control. In the Exadia study, the median achieved time and therapeutic range was only 51%. So again, much worse than what we aim for in these patients. The secondary outcomes or endpoints are shown on this slide. Again, death, very common in these patients, 19% versus 25%. Not many strokes, no such events in the apixaban arm, and one patient, that is 2% of patients in the warfarin arm. Hemorrhagic strokes were not reported, and there were no differences in the rates of major or clinically relevant non-major bleeding between patients randomized to apixaban or warfarin and fenprokumab. That's a typo on the slide, pardon me. This brings us to an overview of the completed trials. The Valkyrie trial was the first one, randomizing patients to the reduced dose of Riva-10 versus any vitamin K antagonist. The second one was Renal AF with apixaban 5 versus warfarin, and the Exadia trial being the last one, randomizing patients to the reduced dose of apixaban versus fenprokumab. You can see that in comparison to bleeding and death, thrombotic events and especially ischemic stroke was quite infrequent. Rates of major bleeding in absolute terms and in relative terms, and especially death, was very common. I believe there are some lessons to be learned from the trials, although they were quite small, and in the end, probably not. They're not able to change clinical practice at this time. And there are some similarities that I want to point out to you. All of the trials did not have a control arm of untreated patients, that is patients not receiving an oral anticoagulant, but randomized patients to receive a vitamin K antagonist or a factor Xa inhibitor. All the trials were limited in sample size and in follow-up duration, and very few events. There were significant challenges to patient recruitment in 2 of the trials. That was in Renal AF and in Exadia. In Renal, less than 2 patients were randomized per center and year, and that in Exadia was even worse, with less than 1 patient enrolled per center per year. So the patients that we find in these trials are probably even then super selected, and it seems to be very challenging to get these patients enrolled in adequately powered and randomized trials. We've mentioned this a couple of times now, but good INR control seems to be difficult to achieve with a vitamin K antagonist in patients who are on dialysis. And the range that we've observed in the 3 trials was quite poor at 44 to 51% therapeutic range overall. Thrombotic events and stroke, that is what we're going for with oral anticoagulation, were relatively uncommon, but the rates of major bleeding and death were very high. It's good to see that there are some ongoing trials. They're listed on this slide. The key trials, we have 4 of them, and the first one is the AVK dial trial, which randomizes 850 patients to a vitamin K antagonist or no anticoagulation therapy. Results are expected later this year. The Danish Denmark trial is randomizing 718 patients to receive, again, a vitamin K antagonist, but they're only using warfarin here, versus, again, no anticoagulation therapy. Results expected to be available in the next year. The SAFE-D trial is probably too small to change clinical practice. This is a pilot trial with 3 arms, randomizing patients to apixaban with the full dose, warfarin, or no anticoagulation. Also here at the clinicaltrials.gov, information says that the results will be available later this year. However, I think the most informative of the trials and probably the most interesting is the SAC trial that is coordinated in Sweden. It's sort of difficult to find information on the trial on the internet because it's not registered with clinicaltrials.gov. To find out more about it, you should Google it or click on this link that is provided on the slide. The SAC trial will randomize 1,500 patients with AF and end-stage renal disease on dialysis to receive the reduced dose of apixaban, which is 2.5 milligrams twice daily, and will also contain no oral anticoagulation as the control arm. It's good to see that all of the trials have an arm of untreated patients. And again, I think the trial that will most likely influence or change clinical practice is probably going to be the SAC trial. So let's review this in some more detail. SAC stands for stroke prophylaxis with apixaban and CKD5 patients with AF. And again, this study will randomize patients with AF who are on dialysis 1-to-1 to receive either apixaban at the reduced dose or no anticoagulation. These patients will be recruited from centers in 3 Nordic countries, as well as Iceland and Poland. Very typical inclusion criteria, straightforward and very similar to what has been done in the published 3 trials that I showed you a little earlier. There are some exclusion criteria as well, all referring to absolute contraindications of oral anticoagulation in this cohort. The SAC trial is powered for superiority to show superiority of the reduced dose of apixaban twice daily versus no anticoagulation for the primary outcome, ischemic stroke. The investigators will also look at the composite of intracranial hemorrhage or fatal hemorrhage as a secondary co-primary endpoint. Safety will be analyzed in a very straightforward manner. The bleeding endpoint is ISTH major bleeding, and the other outcome that will be looked at is all-cause mortality. However, we'll have to wait a little more to learn the results. Right now, the investigators believe that they'll be able to publish and report the results in about 3 years from now. Before we open up the seminar for your questions, let's review the current guideline recommendations for Canada. These are the 2020 CCS, Canadian Heart Rhythm Society guidelines for the management of AFib. And you can see that in patients with a creatinine clearance of less than 15 milliliters per minute, or patients who are on dialysis, you may use warfarin, indicated by the yellow box here, but the guidelines, I think, correctly report that there are no RCT data. There's no RCT ever done that would have shown superiority of warfarin over no anticoagulation in this population. And rightly, mentions that the observational data that we have available are in line with the possibility that warfarin actually causes harm in these patients. With all of the DOACs, including apixaban and rivaroxaban, it's a little easier. The red boxes clearly indicate that you should not routinely use a DOAC in a patient on dialysis. The product monographs are pretty clear that they're all contraindicated in this setting. This brings us to the end of our seminar. Thank you again for the possibility to speak here, and we're now looking forward to answering your questions.
So as we may have a few minutes left, maybe we can quickly go through the very little evidence that we have also with direct oral anticoagulants for management of venous thromboembolic disease. And this will be a very short presentation because actually the evidence is almost non-existent. So we know that venous thromboembolic disease is more common as kidney function declines, and most importantly is associated with worse clinical outcomes. So as you can see, patients on dialysis who got a pulmonary embolism have higher rates of mechanical ventilation or cardiac arrest compared with patients with preserved renal function. And as this seminar is for the CanVector public, I do not need to remind you that treatment of use of anticoagulation is a little different in the VT setting, especially when you use a DOAC up front. Also, I will remind you that dose reduction was not studied with apixaban or rivaroxaban, but only with edoxaban in this setting. and that all RCTs stopped at the GFR of 30. There is only one observational study with apixaban compared with warfarin for VTE treatment in dialysis. It used the same United States Renal Data System dataset. The authors were able to identify 3,000 apixaban users and 9,000 warfarin users. They used sophisticated statistical techniques, including inverse probability of treatment and censoring weights, and they created 2 pseudo cohorts that were well balanced for the baseline characteristics. However, they do not provide any information on which dose of apixaban was used, if a low molecular weight heparin was used and for which duration before switching to apixaban, and they do not provide also any information on time in therapeutic range for patients on warfarin, most likely because this information was not available in the data set, in this retrospective data set. And they saw that clinical outcomes are better with apixaban, less recurrent venous thromboembolic disease compared with warfarin, and possibly less major bleeding, although no effect on mortality. However, these results may also be confounded by indication, the sicker patients being assigned to warfarin and less sick to apixaban. This study most likely opens more questions than it solves, because we don't know anything about the duration, about the dose, and about the profile of these patients. And these results can only be hypothesis generating for now. My hope is that the factor 11 inhibitors may revolutionize management of venous thromboembolic disease and of stroke prevention for atrial fibrillation in this setting. There are some studies ongoing with antisense oligonucleotides in dialysis. Results are not yet publicly available, but look promising as far as I know. So this is the topic of another talk, and I hope that we will have more evidence in the years to come.
Well, thank you for such excellent talks. We have one question that's come in so far. And it's asking about the use of dual antiplatelet therapy for stroke prevention and atrial fibrillation, and how it compares to warfarin and direct oral anticoagulants.
To my knowledge, there are no randomized, no data from randomized clinical trials. But in the past, in a general population of AFib, this question has been addressed. Clearly, where the combination of clopidogrel and aspirin was inferior to a vitamin K antagonist, warfarin in this case, in the active W trial. So my impression would be to not study this and probably not use it clinically. And Dr. Mafrikanis, you see these patients more often, but I think platelet dysfunction is quite common in these patients. So my impression would be to rather avoid this treatment.
Yeah, I fully agree with what you just mentioned. I think that it's probably not working as well in the general population, so it will become even more problematic in advanced renal disease. As we're talking about antiplatelets, what you already showed about these trials is quite remarkable, that 30 to 40% of patients on oral anticoagulation were also on aspirin. Or on another antiplatelet agents, and we now know that this is not good practice. After the publication of the AFIRE trial, for example, the general population, if you choose to use an oral anticoagulant in this population, you should most likely stop the antiplatelet agent unless you have a recently inserted stent. Otherwise, the risk of bleeding may be exponential.
Yep, couldn't agree more.
While we wait for some other questions to come in, oh, here's one. So this question's asking about DOAC for VTE with creatinine clearance of 15 to 30. In terms of dosing, would you still usual loading dose? Is there a preference to use more tinzaparin or a different liquid heparin initially, and then transition to a DOAC? Just curious to hear your thoughts on it.
So, yeah, that's a very interesting question. I fully agree with the colleague who is suggesting using the low molecular weight up front to avoid this time period where you would have to use apixaban at 10 BID or rivaroxaban at 15 BID. And we don't really know for apixaban or rivaroxaban, which are the two less renally excreted agents, what is the right dose. We have some PK data from Aristotle published by Stanifer in Circulation a few years ago, suggesting that perhaps 2.5 BID might be more interesting as kidney function declines, but this may be true closer to a GFR of 15 rather than to GFR of 30. And other factors also play a role, as the body weight or the patient's age. What I personally do, but get this as personal opinion and not as strong evidence, is exactly what our colleague is suggesting, using actually the low molecular weight for the first week at least, to avoid using a DOAC at high dose. And then, especially for patients who are closer to 30 than 15, I may consider edoxaban at 30 milligram QD because it was the only agent that was dose adjusted in the RCT for VTE. So in Hokusai VTE, they used actually 30 and not 60 of edoxaban. So we have RCT data, although RCT stopped at 30 of GFR as inclusion criterion, one could reasonably argue that when you have patients who are closer to 30 than 15, most likely using 30 of edoxaban should be appropriate after having loaded them with a low molecular weight for the first days.
Great. Thank you. And Dr. Mavropanos, you brought up some, I think, interesting pharmacokinetic data during your talk. Is there much role to drug levels in clinical practice, or do you advocate for their use in this setting?
So we have used that sometimes. We had some patients in dialysis who had actually very bad vascular calcification or history of calciphylaxis. And these patients wouldn't be good candidates for rivaroxaban or for warfarin. And we used actually the anti-10A level to measure the drug trough level and peak level, and then try to deduce from the information that we have from observational studies if we are on target. But you know, the problem with oral anticoagulants is all direct oral anticoagulants is we don't have a good relationship between clinical outcomes and drug levels. So all this becomes more theoretical, and I don't have the evidence to suggest this as a widespread practice. Now, on a case-per-case basis, if you have somebody that you choose to anticoagulate with a DOAC and has very low renal function, maybe it's a good idea a few days later to draw a trough and a peak level and try to find out where you are with respect to what you should get with this agent.
Yeah, no, I have to admit, it's like a guilty practice of mine to order drug levels. I just get it makes me feel good when it comes back in a somewhat normal range. Great, thank you. Another question we have, getting an idea, should we be anticoagulating patients with atrial fibrillation and hemodialysis at all? Is the CHADS VAS score useful risk stratification, or should we ignore it in this population?
That's a very important question. To my knowledge, the CHADS VAS score has never been validated in this population. You know, the score has some limitations even in the general population of patients with AF. Interestingly enough, all of the trials are using the CHADS VAS score to you know, guide eligibility of patients into the trials. So I think in the end, when we have the data from the two big warfarin trials that are testing warfarin versus no anticoagulation, as well as the SAC trial, which was the last one I showed you, which is apixaban reduced dose versus nothing. And they're all guiding patient selection based on the CHA2DS2-VASc score, and that is the usual cutoff of 2 for men, and some of the trials are using 3 for women. So I think to answer the question, it's tough, but when we have the data from the trials, we'll probably guide patient selection based on CHA2DS2-VASc. I mean, if you look at the patients, at the typical patients who are enrolled in the published trials, you can see that most of them would have had a CHA2DS2-VASc score of easily more than 2. Hope that helps.
That I fully agree with what you said. Everybody gets at least a point, if not 2, with the CHA2DS2-VASc score. Anne de Vries, who did the Valkyrie trial and the rivaroxaban PK study, she has recently suggested in one of her publications in NDT a new score for risk stratification in dialysis, but this has not been validated for now, as far as I know. Yeah.
When I review the trials, I'm always struck by the difficulty recruiting patients in the small sample size. It just seems counterintuitive to me. These are 2 common disorders. The patients are in hospital already. So perhaps if you could speculate why it's been hard to recruit, and SAC's coming out or planned 1,500 patients, much higher than any other study. Is that a pipe dream? Or do they have different strategies that is going to facilitate recruitment?
Yeah, so I know that in the renal trial, in the Exadia trial, that most patients, or actually most physicians, have already made up their mind of the use of oral anticoagulation based not on data, but rather their experience, and they were not willing to randomize their patients who were faring well on the current treatment into the trial. So that was a problem in renal and both in Exadia. I know that the SAC trial is coordinated in Sweden, and in the Nordic countries they have these national registries, and SAC will actually be a registry-based randomized trial which allows very easy follow-up of patients, and the outcomes that we're looking at are quite easy to assess. They're all captured by essentially automatically. So there are some advantages to conducting trials in Northern Europe. So that may be a factor why SAC could be successful.
Well, that said, I think if they have 500 centers, they will probably be successful in enrolling. But if they have less than that, I'm not convinced that they will reach 1,500. A country like the United States with 400 million population, 350 million population, and more than 1 million on dialysis over several years, not all at the same time, of course, and they were unable to recruit for renal AF. One of the reasons was the high dose they elected to go with. But still, Northern European countries have lower incidence of diabetes, lower incidence of renal failure. Unless they have many centers, I am quite skeptical about achieving the 1,500 patients, but I hope I'm wrong.
And then Dr. Mavrikans, just building on, you mentioned previously about using edoxaban at the dose reduced for patients with creatinine clearance of 30. Would you apply that as well to patients with creatinine clearance down to 15?
Yeah, as kidney function approaches 15, it's becoming more problematic because we do not have good PK data with edoxaban in this population. We have just a single dose study in dialysis that is useless, as we saw before, because you don't account for renal accumulation. So it's becoming very, you're becoming very nervous, if you are, also from other studies that edoxaban increases the GI bleeding risk, and compared with LMWH, that was in other settings, but it may also apply to renal patients. So I don't have a recommendation to make. You have probably to judge, taking into account patients' profile, preferences. I have anecdotally done that in patients who had the option between LMWH and edoxaban for cancer. And they also had advanced renal disease, and the patient was telling me that there's no way that I will ever continue with injections, and the patient has bruises all over the place, you know. So in these cases, well, you need to inform the patient. I think it's probably still more appropriate to use edoxaban therapy than warfarin in somebody with a GFR of 16 or 17. But again, this is personal opinion, and I don't have the data to support it.
Question regarding commenting on use of apixaban or sort of roxaban in patients at extreme of stroke risk, so CHADS 5 or 6 with multiple thrombotic risk factors, whether there's any data specifically around that population.
Yeah, Dr. Mavrokanis has shown some data earlier today that are, observational data. I think what we have to understand is that we use CHADS VASc to guide us in stroke prevention, but we should not forget that major bleeding and death are so much more common in a general population of patients with AFib, but even more so in patients who are on dialysis. So I think the intention is good, but in the end, we can't be certain without the data from adequately performed randomized trials to know that this is actually beneficial. It may be even causing harm. So I personally don't see very many patients who are on dialysis. At my center, we have the current practice to not anticoagulate at all, which is in line with I guess, clinical equipoise. Dr. Mavrokanis, you see these patients much more often. What do you think?
I agree exactly with what you said. So also, I do not anticoagulate the majority of patients with atrial fibrillation. Also, if you think of that pathophysiologically, you may say that, well, a patient with paroxysmal AFib may actually go from sinus rhythm to AFib and back when close to dialysis, due to the volume shifts when we ultrafiltrate them or to the electrolyte changes. But this is the time period that they are also receiving parenteral anticoagulation for the circuit. So they are protected, at least temporarily. I understand that the LMWH that we give them does not last 24 hours, but maybe does cover the interval when they switch back and forth from sinus rhythm to AFib, which probably also the time that you want them anticoagulated the most. So this may explain why we see such a low number of strokes in clinical trials, but a lot of bleeding. And all these scores have, if you look at has bled and hemorrhage score, some of the items are common to the CHADS VASc. So a high CHADS VASc is also associated with high bleeding risk, not only with high stroke risk. But if the renal AF and Azadia trial showed something, is that bleeding is at least 10 times more common than stroke. So I fully agree with what Dr. Bench suggested, probably do nothing, although we feel bad as physicians, if we use nothing as treatment, is probably the most appropriate until more knowledge becomes available.
Great. Well, we realize we're approaching 12 o'clock. So I just want to thank you again for an excellent seminar. If you had any last thoughts you wanted to share, if not, I guess we can end there. And just encourage everybody to complete the seminar evaluation and stay tuned for our next seminar in May.
Thank you very much.
Great. Thank you so much.